Main. Good afternoon, everybody. I would like to thank the organizers for inviting me to this lecture. I just want to give you a brief, very brief introduction about pharmacoeconomics in our area. Telling about outcomes, costs, and perspectives, the main pharmacoeconomic evaluation types, evolution and use of pharmacoeconomics around the world and in the Arabic area, and giving some examples in Jordan and other countries, and also some take-home messages. Actually, all economic problems arise from scarcity. What we mean by scarcity, it is a relative issue. It does not mean nothing, but always, if you have any resources, always there is more needs. And if you satisfy a certain need, you are always looking for another needs to be satisfied. So always we have scarcity. And to define economics in two words, it is the science of choice. Good economists choose to fulfill the first priorities first, with the resources available, which are scarce. Outcomes research within health economics is the science that evaluates the effect of healthcare interventions on patient-related, if not patient-specific, clinical, humanistic, and economic outcomes, what we call in health economics or pharmacoeconomics an eco model. Clinical outcomes are medical events which are resulted from disease or treatment. And these are mortality, morbidity, curing, prophylaxis. Humanistic outcomes, which we are away from other nations in our countries to consider these outcomes. Again, it is the consequences as a result of disease or treatment on the patient himself, and which will affect his physical function or even social function and well-being. Well-being, depression, and psychological things. Social functioning, when we have a diabetic patient, they became inactive socially because they don't want to go out for the reason of taking a lot of water and going to the bath. Economic outcomes is translating these two clinical and humanistic outcomes into money. We always hear that healthcare cuts don't heal. This is true, but by pharmacoeconomics, we don't cut healthcare costs. Pharmacoeconomics is not about determining the cheapest healthcare. It is about determining alternatives that provide the best healthcare outcome per dollar spent. It is cost effectiveness. Pharmacoeconomics is critical to the optimal allocation of healthcare resources, the choice, and also it works like a balance between the two sides of the equation, costs and consequences. Cost effectiveness of medicines became now the fourth hurdle. We hear 50 years ago that we need an effective and safe medication, then we moved to quality medication, now we move to a cost-effective, safe, effective, and quality medication. But the problem facing us is there is always an inadequate understanding of the basic terms of pharmacoeconomics, and mostly all the cost-effective publications are sponsored by companies, so there is a distrust of these data. What we mean by pharmacoeconomic evaluations is to identify, measure, and evaluate the two sides of the balance, costs and consequences. And the overall goal of pharmacoeconomics is to achieve the most efficient use of these resources, taking into account the cost and the value for any given technology. There is new terms in pharmacoeconomics or health economics. Just want to tell you about it. Health technology assessment and what the difference between pharmacoeconomics and health technology assessment. Medical technology in healthcare is any intervention that may be used to promote health, to prevent, diagnose, or treat disease or rehabilitation. So pharmaceuticals or pharmacoeconomics is part of this health technology assessment. And health technology assessment includes, besides pharmaceuticals, devices, procedures, systems, organizational systems used in health, and even strategies and services. Also, just 3 or 5 years ago, we heard the Americans say something called comparative effectiveness research. It is the direct comparison of existing interventions to determine which work best for the patient. And this is, they look for the outcome only, and they don't look about any cost, although there is resource, scarce resources. To give you an introduction about the first side of the balance, the costs. We have a lot of types of costs. Just I want to focus on what we need in healthcare or health-related costs. Costs are resources consumed, and these resources can be people or human resources, money, equipment, or time. And we have major 3 types of costs. We need to have the total cost when we are evaluating pharmacoeconomics or pharmaceuticals. We have fixed costs and variable costs. Fixed costs that don't change with the outcome or the output, but may vary with time, like salaries. Your salary is the same at the end of the month, but maybe after 1 year you can get something more. And variable costs, these costs are which vary with the level output. If you have 1 kilogram of statin, this will produce, for example, 10,000 capsules of simvastatin. But if you have 2 kilograms, you will have more output. Opportunity cost is something very important in health economics. What we mean by opportunity, it's the value of the alternative that was forgone. If you use a certain amount of money to purchase a certain pharmaceutical product, so it is not available to be used for another purchase. And we call this an opportunity cost. Incremental costs are also to give this vaccine to the patient. This is a cost because you are preventing a disease. You are not giving a vaccine to the patient because you want to feed him. No, because you want to give him a prophylaxis or to prevent a disease. And these direct costs are 2 types, medical or non-medical. Medical, it's the medical things like drugs, medical supplies, and physician visits or lab tests. The non-medical direct costs are which resulted from illness or disease, such as transportation. We will not find somebody who is going in the ambulance just for her sightseeing. He is there because he is sick, or he is in the hospital because he wants to take chemotherapy, and they gave him certain special diet because he is diabetic or hypertensive. Indirect costs, this is the major problem in our countries. We did not even calculate these costs. What we mean by indirect costs, the changes in production capacity, again, as a result of disease or treatment. Somebody who is working as driver, if he will not go to work, he will not gain money. So he will lose his productivity, and this is a cost. Why? Because he is sick. And these are morbidity costs, missing working days or lost productivity, and mortality due to premature death. You are supposed to work till 60, and if you have a disease and you passed away when you are 40, we want to calculate the 20 years that we lost your productivity because you are away. Intangible costs, again, this is the most difficult. It is the cost of pain and suffering, and these are the non-financial outcomes of disease or medical care. The other part of the balance is the consequences, and we have the consequence is the effect or the outcome, and we have 2 major types: the positive or beneficial or desirable outcomes. If you give a medication or an antihypertensive to a patient, you're supposed to give him this medication to reduce his blood pressure. This is a desired outcome. This is a positive consequence. But sometimes you see some harmful side effects, and these are outcomes we have to calculate, although we don't need it, and it is undesirable. Also, we have sometimes something called intermediate consequences, and this issue is very important, especially when there is an ethical and time issues and cost issues. For example, you always your target is to reduce the level of cholesterol in the blood, but this is not the final outcome. This is an intermediate because it acts as proxy for more relevant final outcome, which means to reduce death or to decrease the myocardial infarction, and you save lives for people. Perspectives are the point of view, and these are very important in pharmacoeconomics because this will influence the cost and the consequence. What we mean by perspectives, the viewpoints. So if we want to evaluate two drugs or two strategies, costs and consequences from the societal perspective, this is the broadest, and we consider the whole society. So we take into consideration the viewpoint of the whole society. But if you just have it from the perspective of the provider, you go and calculate only the true or actual expenses. For example, if you have your friend or your brother have a dental clinic and you want to go and make your teeth, he will tell you, come and at 7 o'clock because I will not have any patients, because he wants to save his time and money, and he calculated only the actual expenses, and we call this provider or hospital perspective. The patient perspective is the cost that the patient pay out of his pocket, the co-payment, the portion that is not covered by the insurance. And also we have the payer perspective, which are the employers or the charges allowed. If you are allowed through your insurance company to cover your eyes or eyeglasses or teeth, this is called from the perspective. Why these are very important? Because the cost here is different from the cost here, different from the cost here. Also, if we are going to evaluate any two medical technologies, always we have two major conditions. We have to have costs and consequences to be compared, and we have to compare at least two alternatives. We cannot compare the certain drug with itself. We have to compare it with others, and we have to compare consequences and costs. Otherwise, it will be partial evaluation. And what we mean by full pharmacoeconomic evaluation, we need to compare both costs and consequences, and we want to compare at least two alternatives or more. This leads us to the major 4 types of pharmacoeconomic evaluations, and we will end up that there are only one type. The first type is cost minimization analysis or cost analysis. It's one part of the equation in which we have two products give the same outcome. So if you have the same output, so just select the least expensive. If you have two antihypertensives with the same dosage form, same generic and originator, the two are, for example, fosonipril, 10 milligram tablet, they're supposed to be therapeutically equivalent, and this must be evidence-based and statistically confirmed. If you have the same output, so you must go and select the least expensive. The other type is cost effectiveness, the gold standard for pharmacoeconomics. Costs are expressed in cost effectiveness analysis in monetary terms, and the consequences are measured in their natural units. For example, if you are giving an antihypertensive, so the natural unit is mmHg. If it is chemotherapy, life saved, cases cured for antibiotics, for prevention and prophylaxis, also we calculate it as its natural unit. Again, what we mean by cost effectiveness, it's the relation between the value of the effect to its cost. So we have two major questions. Is the extra cost justified by higher efficacy? Or the same question another way, is the extra benefit worth the higher cost? I want to pay more. Is this justified or not? And they calculate this using incremental cost effectiveness ratio, and Tilly will tell you about this. Cost-effective therapies, we have 4 scenarios. If you have two alternatives, one is less expensive and at least as effective as the other, it is cost-effective. For example, two generics, we take the lesser. And if we have a proton pump inhibitor versus nizatidine, we all know that proton pump inhibitors are more effective than H2 blockers, although nizatidine is very expensive. So this is the first option. The second option, if you have two alternatives, one is more expensive and more effective, but the additional benefit worth more than the additional cost, so you go for it. In reflux esophagitis, proton pump inhibitors are more effective and more expensive than antacids, so we go for it. It is cost effective. The third option is less effective and expensive or less safety, but we don't need the extra benefit. So again, you don't have to pay more for something that you don't need. For example, doxorubicin formulations. We all know that one vial of doxorubicin is around, acquisition cost is $20. And there is a pegylated doxorubicin which is $700 just for 3% cardiotoxicity less. And the fourth one is less expensive and less effective. For example, if you have proton pump inhibitor compared to an antacid just for an hyperacidity after lunch attack, you don't need it. So you go for the lesser one. This is the cost effectiveness plane, and Terry will tell you about it. We have costs and effects, what we call qualis. And if you have a new treatment that is better than the current treatment and cheaper, this is the cost effective, what we call dominant. And if it is more expensive and worse or work less or not effective than that or less effective, it is dominated, we don't need it. But what if it is better and more expensive? The answer, it is cost effective if you take a big health gain with a small cost. And the answer will be no if you pay more, like doxorubicin, with small gain in health. And this leads us, where is a cut point or threshold? And this depends from disease and disease, from country to country. Always the cost-effective therapies are if you have more cost but justified with more benefits. Okay. Cost utility, the fourth type, it's a specific type of cost effectiveness in which the outcome can measure more than one outcome. What we mean by this, we need to measure quality of life in units of utility. It's not only clinical, but also quality of life. For example, if you have chemotherapy, always if you give a chemotherapy to a cancer patient, you increase survival. Instead of dying after 2 years, he will die after 5 years. So you gain quantity, 3 years. But the quality of life is down because he is taking chemotherapy and he will have a lot of problems. The second example is hormonal replacement therapies. You improve patient quality of life, not to have, for females, not to have osteoporosis later on, but mortality increases. Instead of dying on 65, they will die on 60, for example. Okay? Intermediate outcomes are not working or not appropriate for use in cost utility because we need quality of life, we need the final outcome, we need the patient preference in this regard. It's very difficult to measure these utility values, but we used to express them as cost per quality. Quality means quality adjusted life years gained. It's a comprehensive measure for both quantity and quality, and sometimes they gave it another name, DALY, or disability adjusted life years. You improve quality or reduce disability, it's the same, and they gave it death from 0 and 1 perfect health. And this will show you the quality or quality adjusted life years. If you have 2 times, he will die after 7 years or he will die after 11 years. You improve his quantity, years, and also it was 80% quality of life reduced to 50%, and you give him a therapy. So this will be the difference in the outcome, which we call quality adjusted life years. Okay, the fourth type is for cost benefit analysis. If you can calculate the cost in money and the outcome in money, this will be perfect because it will be a calculation. But this is very, very difficult, and it's usually used by things like materialistic things, such as building a big general hospital versus building many smaller specialized hospitals. This is a comparison between. Evolution. Pharmacoeconomics, when it was started, where we are now. It was started in Australia in 1993 when they start asking all pharmaceutical companies to submit a detailed economic analysis to support their case when they are submitting their files for registration. And they developed guidelines which received considerable publicity and have proven to be a catalyst for other countries such as Canada, New Zealand, United States, and United Kingdom. And they start doing their own, New Zealand and Canada, their own guidelines for evaluation, economic evaluation of pharmaceuticals in 1993 and 1994. In Britain, they started encouraging the use of economic evaluation for new drugs in 1996. It was an agreement between the industry and the government. And NICE, National Institute for Health and Clinical Excellence, Special Health Authority, they influence prescribing by using cost effectiveness, and it is now one of the best references regarding cost effectiveness all over the world. In general, it started in Europe in 1999, and also in the United States. It's not a formal requirement, but in pharmacy and therapeutic committees, always they put in the drug formulary drugs that are cost effective, and this started 2004. If you want to go through this in details all over the world, you go to this website, International Society for Pharmacoeconomics and Outcomes Research, isbor.org, and you will see the total list of guidelines how to make or submit or evaluate a pharmacoeconomic evaluation. And there is some specific guidelines for certain countries. What about our region? We faced a lot of problems in the Arabic-speaking countries because there is a lack of healthcare data, which creates a major barrier to the application of pharmacoeconomics and outcomes research in these countries. There is no perfect local data for health outcomes research and economic evaluation. If you have good quality data in one research project, we use it for this research, and we need to adapt this to our local settings for each country. The problem also of the culture of using paperless or the IT is still there. We need to increase this awareness, and we started 2006, just give me 5 minutes, through learning and training. Since 2006, we have in Jordan, Saudi Arabia, and Qatar, it is in the curriculum obligatory course of pharmacoeconomics. And also we conducted a lot of training workshops in Jordan, Saudi Arabia, Oman, and to an extent in Emirates and Lebanon. Libya, it was 2 months before the revolution, so it couldn't done. We have also participated in many international and specialized conferences. In our countries, we have local chapters. It is part of the International Society of Pharmacoeconomics. We have chapter in Jordan, Egypt, Saudi Arabia, United Arab Emirates, Kuwait, and Qatar. And they don't use pharmacoeconomic evaluation. But in Jordan, we have something I will show you. Oman and Lebanon, they are developing their local chapters. I hope in Libya you will start develop your chapter to follow this. Some publications from Saudi Arabia regarding quality of life, they increased from 2009 till 2012, as you can see. We have worked with NICE in Jordan in 2009, ended up with an international publication in the International Journal of Technology Assessment in Healthcare, piloting the development of cost-effective evidence-informed clinical pathway managing hypertension in Jordanian primary care. And this is the output of that publication. How to have, like a clinical guidelines, we have a cost-effective guideline. We also in Jordan translated the 36-item short form, what we call SF36. This is a questionnaire to measure the outcome. So translated in 2008 in Arabic, and we used it to evaluate some services. We also used new medications to be priced in Jordan, as I am a part of the pricing pharmaceuticals committee in Jordan. They submit their file with the cost, and this is what they submit. In Jordan also, in the last drug and pharmacy law last month, we have now 2 members in the pharmacoeconomists in the pricing committee, and 1 member by law has to be for the appealing committee. Take-home messages. Finally, what we need. If economic evaluations drug theory are to be used, they must be credible and accessible. Although traditionally the key concern of decision makers was the initial acquisition cost, but we want to move beyond this cost containment and consider what health benefit might be gained from increased expenditure, and this will not be at the expense of quality. To improve availability and access to new medicines, we need to enhance policymakers' awareness. 2 slides, only 2 slides. Awareness or need for real-world data, develop and apply pharmacoeconomic guidelines, mandate pharmacoeconomics health technology assessment study using local data, establish national level healthcare database registries, medical registries, and increase the awareness and expand the awareness of pharmacoeconomics. We need to increase the awareness of cost effectiveness in the Middle East. Cost effectiveness is not about the cheapest selected medication, but about obtaining the highest value for money, the maximum gain per resource spent. Encourage incorporating pharmacoeconomic evaluations in the pricing or reimbursement in the Middle East, particularly for the new expensive medications. Thank you.